A 60-year-old female patient presented with a severe head injury, and the patient was brought to our ER where she was evaluated with CT brain and CT C spine. CT brain was normal, but her CT C spine showed type 2 odontoid fracture, and she was evaluated with MRI, which showed there is a beaking in the spinal cord with the displacement of fractured odontoid segment anteriorly. This is causing mild compression of the cervical cord by the C1 posterior arch. So she was planned for C1 C2 fixation with removal of C1 posterior arch. Skin incision is placed from inion to C6 level. After giving the skin incision, subcutaneous tissue is exposed and retracted, exposing the C1 arch and C2. The C1 arch is exposed till the lateral part, and C2 is also exposed starting from the spinous process with subperiosteal elevation. Later, sharp dissection is done over the C1 posterior arch, reflecting the um, muscle attachments, periosteum over the posterior arch. The periosteum is slowly elevated, extending into the lateral aspect of C1 arch. Later, the dip in the posterior arch is identified, which is connecting to the lateral mass of C1. This is exposed. Here, the venous plexus are more around the C2 ganglion. Careful hemostasis and packing the C2 venous plexus near the C2 ganglion is done, and switching technique is done. After doing on the right side, we will switch to the left side, exposing the C1 posterior arch and the attachment of posterior arch to the lateral mass. Once you encounter any bleed, it is packed with Surgicel and cottonoids and later shifted to the other side. By the time the other side is exposed, there will be hemostasis. We can achieve the hemostasis on one side. This process is repeated till the exposure of C1 lateral mass. Later, the adhesions over the C2 ganglion is removed, and we follow the C2 posterior arch till the C1 C2 junction, C1 C2 articular junction. All these steps are to be done under high illumination and high magnification, as there are vital structures like vertebral artery is very near to the C1 posterior arch, which is crossing over the C1 posterior arch in the vertebral artery groove. We slowly identify the C1 lateral mass by careful, sharp dissection and dissection using the dissector. Later, we also separate the adhesions over the C2 C2 lamina and the C2 we will expose the C2 pedicle. Here we can see the articular junction between the C1 and C2. Again we can see there is oozing from the venous plexus around the C2 ganglia, which are slowly packed and with gel surgical sheet and with cotton. And we again switch to the right side. Here we can see the attachment between the lateral mass and the C1 posterior arch. We slowly drill the C1 posterior arch over the attachment, and we make a room. We decorticate the bone for for placement of the screw. After careful decortication of the C1 posterior arch over the attachment into the lateral mass, we drill it with handheld drill, and we make while drilling the C1 lateral mass, we also have to have the tactile feel, and we have to see the purchase, and this is done under CM guidance. Now we are placing the C1 lateral mass screw. This is a 24 screw, and it is placed slowly in the direction which is around 5 to 10 degree medial angulation, and should be directed towards the anterior tubercle. Next we are placing the C2 pedicle screw. The C2 pedicle screw, we do a decortication with the diamond burr, and after carefully watching the direction of the C2 pedicle, we can directly visualize the C2 pedicle direction, and we place the screw in the same direction. Now we again switch to the left side, and we expose the C1 posterior arch and its attachment to the lateral mass. Now we can see the C1 posterior arch attachment attaching over the lateral mass. Now this is the entry point where we will drill the slightly drill the posterior arch, and I prefer to put a screw through the attachment between the lateral posterior arch and the lateral mass. In this way we can easily avoid any dissection, further dissection, and we can also save the C2 ganglion. Now we are putting a now we are using a handheld drill, and making way for the screw. In all these steps we can see slight ooze from the C2 venous plexus. The drill is being advanced, handheld drill is being advanced and making it, and now we are checking it with a probe. After that, now we are introducing the C1 lateral mass screw, which is in the same direction, which around 5 to 10 degree medial angulation directed towards the anterior tubercle under CM guidance. Once this is done, we will again place a pedicle screw. Now we can see the direction of the pedicle of the C2. We'll make a we'll make a decortication in the bone and direct our screw in the same way as the pedicle. Placing a C2 pedicle is very easy. Pedicle screw is very easy, and we just need to make sure the boundaries of the C2 pedicle. And once it is done, the next step is fixing the screws with um, a rod. The post-op X-rays show there is a good reduction in the fracture segment along with immobilization of the C1 C2 joint.